Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
The famous painting, A Young Woman at the Mirror by Picasso, brings us to the subject of asymmetry and an appreciation of self-image. It is indeed often the mirror image which brings to the individual's attention the fact that there is an element of asymmetry or disharmony in the features of the maxillofacial region which they would like to have altered through the possibilities of correction via orthodontic and orthognathic surgical management. This we will see in the following example of the surgical correction of asymmetry in the maxillofacial region. We have with us today a patient who is a candidate for surgical correction who has had some pre-surgical orthodontics. Barbara Burton is with us, and Barbara has plans to proceed with the correction of her jaw asymmetry next week. Barbara, about when did you first notice that your jaw was a little different from one side to the other?
I was about 13 years old.
And was that just noticed in the mirror, or where did you happen to observe it?
No, in the mirror. In the mirror.
And you're now 31?
Yes, I am.
The thing that took you to some help for your jaw, was that chiefly the imbalance of the jaw, or were you also having some functional difficulty?
I had trouble chewing and pain on the sides of my face.
You had pain?
Yes.
And that was localized where?
Right about here, where the joint is, and down under here.
Was it on both sides, or was it more concentrated on one?
More on the left.
More on the left.
Yes.
Was there any noise or any other things than pain associated with the jaw movement?
Yes, there was cracking. My jaw would continually crack. I could hear it crack.
And in your chewing, have you chewed more on one side than the other?
Yes, I would chew more on my right than on my left.
And that has been pretty much your habit as you've gone through these years, to chewing on the right side?
Definitely. Definitely. As long as I can remember.
Well, we would like to have a few points observed with Mrs. Burton. If you would have a look at her directly from the front, I think we can begin to appreciate some of the asymmetry that is present. If we come up tight on her, you can see the degree to which, now just keep your teeth together, Barbara, and turn your chin down a little. The degree to which this inferior border of the mandible is below this inferior border. The entire face on this side seems to be significantly lower. Mrs. Burton has been in orthodontic therapy now for several years with Dr. McNamara, and we'll have a look now at what he has been able to accomplish in the positioning of the teeth. She has had these orthodontic appliances in position. Now, if you try to close a little, please, Barbara. That's good. As we look in here, I think with the jaw in this position, if you can drop your chin down just a trifle, we will see that the teeth on the right side are much closer together than the left side. The occlusal plane drops down on the left side, as we'll be able to appreciate. The posterior maxilla on the left side is at a much lower position. You will see that the molar teeth and the bicuspids on the left are much lower than they are on the right, and similarly the mandibular occlusal plane drops off as well. There has been an effort orthodontically to reorganize the arches, make them more symmetric, and level them as much as possible. Now let's close together, Barbara, right all the way down. And we can see the type of malocclusion that is present here, the almost missing contact of the right side, and the left side has compensated in a crossbite fashion. There are a number of dental compensations in this situation that we will be observing. In order to correct the asymmetry, we'll have to plan a fairly extensive surgical intervention, which will entirely reposition the mandible, and of necessity we'll also have to correct the compensated left maxilla. Now we'll just come out with those and ask you to close again. And would you open and close for me? Now close, open again, and close. There is pain on this side, is there when I?
Yes.
Yes. Open again and close. The palpation of the left condyle finds a great deal of difficulty in disengaging it and getting it to move. These features, I think we can appreciate a good bit better with the assistance of the head plate radiographs, which are useful in the diagnosis and treatment planning in this particular patient. So we will now go to the radiographs. This PA cephalometric radiograph gives us a great opportunity to observe some of the underlying skeletal features of this deformity. Notice, if you will, with me, the difference in the level of the angles of the mandible, here and here, how far they are away from the central vertebral midline, and the relative difference in the height of the rami, this on the right being rather shorter than this on the left that goes way up here. Observe, too, this radiograph was taken just recently, the orthodontic appliances that are in place, and the difference in the level of the occlusal plane. The occlusal plane here on the right is high. It tapers off and drops down on the left side. Although the nasal floor is relatively balanced, the maxilla is much longer vertically as it has compensated to drop down to meet the mandible. A more standard view for treatment planning is the lateral cephalogram, which we will now see. Our orientation on the lateral cephalogram indicates the hyoid bone here, and about the only thing that we really can see is the variation in the contour of the mandible. This is the very low left inferior border of the mandible, and superimposed upon it is the inferior border of the right mandible. The angle of the right is at this level. The angle of the left is here. This specialized articulator was developed by Dr. Joe Hall Morris of Memphis, Tennessee, and it helps us a great deal in the treatment planning for such a complex case, beginning with what amount to the standard dental casts, and those are made from the usual impressions, which then have been reproduced to give us the jaw relationship. Two things are accomplished to relate one jaw to the other. First, a bite registration in centric relation, and then a face bow mounting for the maxillary cast. That has been accomplished, and with the help of Dr. Jensen and Dr. Ellis, we have then these mounted casts. From the lateral cephalogram, a simulated ramus is then made of plastic. That's what these are. These are contoured, and we'll see them a little better in a moment. But those then have a registration where the condylar mounting is then transferred from the face bow to mount the maxillary cast, then the mandibular casts are related to the maxilla, and then they in turn are united with the contoured rami in a fashion that then will give us a dimensional relationship of the entire jaws to each other. On the maxillary cast, we also see some lines which have been scribed here. These are registration lines for segmental variations that may be made that then can give us specific dimensional measurements so we know how far the jaw needs to be moved. If we look here, we can see that the maxilla in this segment has been moved laterally to expand the arch. It has also been elevated posteriorly nearly a centimeter, and we can see its former position up here, the red wax merely bonding it in position. So this segment of then the 4 teeth has been repositioned. The target of the maxilla has been modified to take the dental compensations away. Actually, these maxillary teeth have been dropping down and bringing bone with them to try to keep pace with the downward growth of the mandible. If we look at the lateral aspects, we'll see the necessary operations on the ramus. On the right side, because when the mandible is shifted, there will be a considerable displacement, it will be necessary to release this right mandible from its condylar attachments. This will be done with a vertical ramus osteotomy intraorally, probably with a coronoid section as well. This white line is simply a line that helps us as these ramus simulations are attached to the study cast. They are registered again on the lateral cephalogram as the line projected backward from the occlusal plane. So that's a continuation of the occlusal plane. If we now look at the long left side, we'll see the manner in which this ramus is going to be modified. There are a number of choices in orthognathic surgery to modify the ramus. If the condyle were in a normal relationship with the glenoid fossa and the temporal bone, and it was functional, and there was merely a dimensional length here, we would leave the condyle and make our correction in the other portions of the ramus. However, in Mrs. Burton's case, that huge condyle is no longer in the fossa, and it has been giving her pain over many years. As a consequence, we believe that it is better, in her case, to shorten this ramus by a condylectomy. So that will be performed as this side then will be shortened, whereas the opposite side is lengthened. The mandible is shifted, and we reduce this occlusal plane and elevate it to a point where it will be equal on both sides. This particular deformity we believe to be the result of an early onset condylar hyperplasia. This might be demonstrated with the help of an artist's diagram. Although we are all asymmetric in degree, when we have this much difference in growth taking place with an early onset, we can see the manner in which a unilateral macronathism is produced. We have a condyle that is continued to enlarge. We have a ramus that has grown downward directly, has carried the inferior border of the mandible with it, bowing it down. And you recall that Mrs. Burton said she did all of her chewing on the other side. That was in all probability on the basis that the dental compensations trying to get these teeth together didn't quite make it functionally. But as the lower teeth extrude and come upward, they develop all this towering alveolar process with them. And the maxillary teeth drop downward, carrying alveolar process with them. which gives a net lowering of the occlusal plane where the compensations have taken place. In some instances, there is an open bite on this side where the teeth just didn't make it in their efforts to try to extrude to get into functional contact. The ramus tends to be flat, as we've noticed, and because of the downward slope, the incisors in the midline, although in Mrs. Burton's case that had been corrected orthodontically, the incisors tend to tip toward the involved side. So we have, over a long period of time, these variations in the morphology of the jaws, the abnormality in the mandible, we believe primarily, but reflected in the compensations in the maxilla. And these then are the problems in the adult where growth has now stopped, and we are then able to go in and recontour the position of both jaws, which we will plan to do for this patient. Here in the operating room, we find the patient already anesthetized with a nasal endotracheal tube, and after infiltrating these tissues, we're beginning with the left maxilla. We have made an incision vertically through the lateral area and also on the palatal side with an effort to mobilize the left maxilla from the canine tooth posteriorly. Here we are on the palatal side, illustrating the incision that's been made through that dense palatal mucosa, and utilizing an oscillating striker saw, we'll complete the cut into the maxillary sinus above the roots of these teeth. Another cut will be made on the buccal surface in a moment, and we will then complete it across the alveolus. Here we are on the buccal, removing a small segment of bone between two horizontal cuts that have been made with this reciprocating striker saw. We are cutting through the malar strut and carrying the bone division back to the tuberosity. Here we nicely see the mobility of the left entire maxilla, which is going to be intruded significantly, the blood supply based entirely on the buccal flap. We are now checking for the ability to reposition that segment with the help of this intraoperative splint, which tells us we then need to remove a little of that mucosa. And you see the excess mucoperiosteum has just been removed, and we're using 3-ochromic to close the flap first here on the palatal side. We will not be able to get at that after the splint has been put into position. Again, continuing with 3-ochromic, the mucosal incisions are closed here with a figure 8 through the interproximal and through the vertical incision that was in the region of the vertical cut between the lateral and canine tooth. After the mucosal flaps have been reapproximated, we'll then be able to check the position and hold the mobilized segment into this splint. The splint is anchoring, of course, to the undisturbed 3/4 of the maxilla, and here you see the open bite that we intentionally have created on this side. Next, turning our attention to the right ramus, using this 20-degree angle striker saw, we're performing the releasing vertical ramus osteotomy on the right. In order to eventually shift the mandible to the left and close this open bite space that we've created in order to restore the symmetry, we're using skeletal fixation by means of the circumzygomatic wire. This passing needle first being placed medial to the zygoma in the anterior portion of the arch, and then a second needle will be placed, which again goes lateral to the zygomatic arch. Here the passing needle being withdrawn has then established the tract of this 24 gauge stainless steel wire, And this passing needle, which is just a modified spinal needle, is being used as a pathway to direct the other end of that wire, and then the wires will be drawn down over the crest of the zygomatic arch, which is being done now, establishing the anchorage point for the future skeletal fixation. We'll now, after change in gown and gloves and a re-prep, are approaching the remaining phase of this three-phased operation in the left condylectomy approach. Injecting here is simply for hemostasis, utilizing 1 to 200,000 epinephrine in order to reduce some of the capillary ooze. There are many forms of approaches to the condyle, and in this preauricular incision, sometimes the contours of the tragus are followed. In this instance, because we have a very large condyle, malformed condyle to remove, incision is made rather adequately and low. After dissecting through the layers, we are now at the neck of the condyle, and using a reciprocating striker saw again under irrigation, we're making the cut which will release this grossly enlarged condyle that we have seen in the X-ray before. It is delivered with some difficulty because of its size, releasing the lateral pterygoid attachments and lifting it away from the meniscus. We see the fibrocartilaginous surface of this rather tri-lobed and expanded hyperplastic condyle that has contributed so much to the abnormal length of the mandible and the ramus on this side. The histology of this proved to be normal. It was submitted for study. It was normal fibrocartilage, and there was no neoplastic change in the tissue. It was simply too much of it and had grown abnormally. And then returning to the site of the condylectomy, and here we see the stump of the neck of the condyle with rather sharp edges, which are smoothed off with a barrel burr. And after that's been established, the meniscus is left in position, and we will make the closure in layers, reestablishing the capsule first, and now we are up to the level of the fascia and the temporalis and mesenteric fascial layer, and bringing the parotid back into this position with buried sutures. These are threochromic, and then we'll turn to a series in the next layer up of subcuticular fluoroplane, and then have a running stitch of 5/0 nylon as we complete the third phase of this operation. This will be the completion of the condylectomy, and we will then have made it possible to shift the mandible to a symmetric position, bringing it around by way of these several subtractions and modifications, moving the maxilla first into an appropriate level occlusal plane in the midline, then releasing the right ramus by vertical ramus osteotomy intraorally, and then finally completing the foreshortening of the left ramus by removing this dysfunctional and very large mandibular condyle. The running stitch of 5/0 nylon is placed routinely, and now we're into the intraoral aspect of the final closure, utilizing skeletal fixation. This is a circummandibular wire, and a wire then will be placed between this and the circumzygomatic wire, and we're checking out with a intraoperative splint the ability of the mandible to be shifted properly, and then with the splint removed, we are establishing now the final intermaxillary fixation. So the throat pack has been removed, bleeding is all stopped, and we are taking the mandible to its new position where healing will take place in several sites during the next 6 weeks while the patient will convalesce. Here we can see the ease with which the mandible can literally be put in almost any position, and it is brought up to the new occlusal plane of the maxilla, and will be not only establishing the occlusion, but suspending by means of that circumzygomatic to circummandibular suspension wire. Here she is closed completely. A pressure dressing will be applied. She will convalesce in the hospital for about 4 days, and here we will see her post-operatively. Mrs. Burton is returning for a post-operative visit while she is still encumbered by the intermaxillary fixation. She, as we can see, has some improvement in facial symmetry. The midline of her chin is rather directly on, and the degree of tilt to her mandible has been corrected by the surgery. We would show the incision, if you can turn to the right, Barbara. Here, still in a stage of early healing, is the scar from the preauricular approach. At the time of surgery, this condylar head was down at a very low level. That necessitated quite a little stretching at the time to get it out. As a result, she still has some lag in the upper branches of her seventh nerve that we'll demonstrate now. She really is doing quite well. But let's squeeze your eyes tight together now, Barbara. You can see, although she's lifting here well, so there are not any creases on this side, and although she gets the eye closed, it's with great effort, and she's been practicing on that in order to protect the cornea. We'll look inside the mouth now and see the appliances that are in place. She has all of these things that we're aware of: a splint in the maxilla, which supports the this left side that was moved up, and she is suspended from the left zygomatic arch. Barbara, how are you getting along with the liquids? Eating frequently?
Very much. I've gained weight.
Have you really gained weight?
Yes, I have.
Well, that shows a lot of effort.
Thank you.
And we don't have much farther to go before we'll be able to get that jaw open. Yeah. Okay, we thank you very much for coming in at this stage, and we'll see you again when we have all of those appliances out.
Thank you.
Mrs. Burton is in her post-operative convalescence here, and her jaws are held together firmly. We see that she has some restoration of symmetry in the chin point, and if you ask her to turn toward me, please, we'll see where the incision was made and its stage of repair. The condyle that was removed was at a very low level, and as a result of that, she'd had some stretching here on this side. It is our great pleasure today to welcome back Barbara Burton, some 18 months after she had the surgery for her mandibular asymmetry and temporomandibular joint problems. Ms. Burton, thank you so much for coming back. There are a few things that we would like to ask Barbara. First of all, she did post-operatively undergo additional orthodontic treatment, did you not?
Yes, I did.
For almost a year, was it?
Yes.
Mm-hmm.
Yes.
So that the actual orthodontic appliances came off about 4 or 5 months ago?
About that, the end of July.
Mm-hmm. Good. And we are going to ask you a few questions and try to demonstrate a few things here in regard to your post-operative condition, which appears to be happy.
Yes, very much so.
Good. Perhaps you can put your head back for a moment, and if you will look directly ahead, there are a few things that we would like to point out. You'll see that in repose and posture we have regained a considerable symmetry for Mrs. Burton, in that where her left side of her jaw was so severely angulated down, we have correction there. And if you might turn toward me again, Barbara, you could see that if we can come up tight here, the approach to the left temporomandibular joint, you recall where that incision was made, and the relatively inconspicuous position of that incision. Then as she comes back and faces forward again and looks directly ahead, we'll ask her to go through a few activities of facial musculature. You may recall that she had a distinct lag in the frontalis muscle so far as lifting the eyebrow is concerned and the closing of the eye. Could you go through a few of those activities for us? Thank you. So we can see a balance and the restoration of the forehead lines as she lifts her eyebrows. And now squeeze your eyes tight together. That's very good. And pucker up your mouth. So we've asked, thank you, we've asked Mrs. Burton to practice on this, and she's done that very diligently, and that's been extremely helpful. About how often did you work on that in front of a mirror? Do you remember?
Oh, I'd spend a total of about 3 hours every day.
Almost 3 hours. Well,
Yes.
that's a lot of dedicated effort.
Initially, yes.
It was a good cause. There are some things that we would like to also demonstrate about her mandibular function in light of all of the rearrangement that took place. You recall this was a bilateral procedure with osteotomies on both rami and condylectomy on the left. Let's try to open for just a moment here, Barbara. The position, I'll try to close your jaws together. That's good. We'll just look here at the teeth. You recall that the bands were on before, but she has had a great deal of caries activity, particularly gingival level, and there are restorations here. Now, but she has a very balanced bite. Now open, please, Barbara. Sorry, and then close, and open again, and close again. She's able to go farther than that if I had these retractors out. I just wanted to demonstrate a couple of things. Now try to slide your lower jaw forward, please. That's good. And then back. And then off to the left side, and back. And then off to the right side. Thank you. And back. I did want to demonstrate that right excursion, which she indeed is able to make in spite of the fact that the condylectomy on the left side here was extensive and involved detachment of the lateral pterygoid. So we believe, let's just turn over this way, that in facial balance and in masticatory function and in every other way, Mrs. Burton has had a very satisfactory recovery. A lot of the credit goes to her. During the phase of post-op care, you had a little difficulty in the movement of the jaw, did you not?
Yes.
And what did we suggest you do about that?
Exercise, pursing my lips, trying to open my mouth as wide as I could in gradual stages.
We also did use some elastics to guide your jaw motion for a while, did we not?
Yes, you did. Yes.
So that we were attempting to train those muscles, and I must say you've done extremely well with them. Are you having any discomfort now, insofar as jaw movement is concerned?
Not really.
You're able to chew?
Wonderfully.
Yeah. Now again, just open widely. Wide as you can. Atta girl. Beautiful. That's fine. Then close. The joints themselves, the areas in front of your ears, do they give you some discomfort?
A little bit when it's raining. I ache a little.
And is that true of both sides?
Yes. Yes.
And you indicated that there's still, you've regained feeling in your lower lip and most of your face.
Yes.
But there was a little residual deficit. Where was that?
Right here. The size of a quarter.
There's a patch of numbness there.
Right.
We'd interpret that probably as being one of the forward branches of the auriculotemporal nerve, which was divided in the preauricular approach. We're delighted with the restoration of full function of the orbicularis oculi. You can see that the lid movements and the rest of the seventh nerve functions are all intact. We certainly want to thank you for being a very cooperative and helpful and delightful patient, Barbara. Thank you.
Thank you.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.